So again, hello, I'm Rachel Hunter. I'm from University College London, and I'm the moderator for this session on economics of maternal and infant health. And we have three presentations today. We have Tuba from University, both at UCL and University of Birmingham, I've just realized as well. We've got Tom Palmer, also from University College London. And we have Amissa, who's from Muhimbili, and I got this correct last time, Muhimbili in Tanzania. So thank you very much to the presenters, and thank you very much to those who've decided to join us. So we're going to have the three presentations first, presenting for around about 8 minutes, and then afterwards we'll open up the floor to questions and discussions. So thank you again for joining, and I think we can get started now. So Tuba, would you like to kick us off and share your slides, please?
Yeah, can you see my screen okay?
Yep.
Okay, thank you. Hi everyone, I am Tuba from UCL and UCL Partners, and today I'm going to talk about a piece of work I conducted during my PhD at the University of Birmingham. So that's why you see the name of University of Birmingham on the agenda. So let's start with identifying the issue. Smoking during pregnancy is an important public health issue because it has profound health impacts on mothers and infants, and such as ectopic pregnancy and low birth weight. And children who are exposed to smoking in utero are more likely to become smokers themselves when they reach adolescence. Smoking during pregnancy is also a health inequality issue because women from disadvantaged backgrounds are more likely to continue smoking during pregnancy and less likely to quit. Based on the existing evidence, optimum smoking cessation interventions for pregnant women should include financial incentives, frequent contacts with healthcare professionals, a social supporter, and this support should continue ideally up to until 12 months postpartum. At the moment, there is no published trial of an intervention with these specifics. If we look at the existing economic evaluations, there are a limited number of economic evaluations, and they suggest that all interventions are cost-effective, all smoking cessation interventions for pregnant women are cost-effective, and financial incentives are the most cost-effective ones in the UK. However, the existing evaluations has some significant limitations, such as the limited time horizon and the omission of some important health impacts. So that's why in this study, we aim to produce better health economic evidence to identify the characteristics of optimum smoking cessation interventions for pregnant women. And the objectives were to develop an economic model to evaluate smoking during pregnancy interventions, design a hypothetical optimum intervention, and evaluate that hypothetical intervention to estimate its cost effectiveness and cost utility. I'd like to introduce the economics of smoking in pregnancy household model, which is called ECPH model. So the ECPH model includes mother, partner, and child, different to the previous evaluations. It has 5 separate linked components. The pregnancy period is modeled with a decision tree because it is a relatively short time period, and we can see all the steps clearly with a decision tree. And then we have lifetime Markov chains for the mothers and for partners. And then there are 2 Markov chains for the offspring childhood and offspring adulthood. The offspring moves into the adulthood Markov chain at the age of 16. This is because we have the evidence showing that children who were exposed to smoking in utero would be more likely to start smoking at the age of 16. So this is why we decided to have a cutoff at that age. And then here we see the simplified version of the model structure. So women who smoke at conception enter the model at the time of delivery, and they are grouped according to their smoking status and the smoking secondhand smoke exposure by the partners or significant others in the household. If they continue smoking after delivery, then they are grouped as light, moderate, and heavy smokers based on the number of cigarettes consumed daily. The pathway is similar for the partners, and at the bottom here, we see the pathway for the offspring. So this is the mother lifetime model structure. As you see, we have 3 different states for those who quit smoking. This is because the evidence shows that the health impacts of quitting smoking would differ based on the abstinence duration. And those who have quitted smoking for a long time will be less likely to relapse smoking. So by separating these into 3 health states, we were able to reflect on that evidence. And the partner lifetime model is similar to the other lifetime model with an addition of never smoker health state as well, because some of the partners or social supporters might be never smokers. Other states are the same. Then the offspring childhood model includes 5 key health states. One of those is for children who are not exposed to secondhand smoking. And there are 2 states for those that are exposed to secondhand smoking by mother only and by mother's partner only or another adult in the household. And then we have another state for those that are exposed to secondhand smoking by both parents or by 2 people, we can say. And then we have a health state for that. And then this is the offspring adulthood model, which is the same as the model for the partner's mother's partner. Now I'm going to introduce the smoke-free household intervention. That is the hypothetical intervention that we designed. We called it smoke-free household intervention. This was designed based on a comprehensive NIHR report and some other published trials on the issue. The intervention includes initial face-to-face contact, self-help materials, 28 midwife visits until 12 months postpartum, 40 pounds vouchers per negative carbon monoxide specimen for women and their partners or any other supporter. And then on the whole, per household would be eligible to gain up to 2,320 pounds. Because the effectiveness and the cost of this intervention was designed based on existing published trials, we designed 2 different scenario analyses. So one base case scenario and one cautious case scenario. And the comparator was the standard care in the UK, which is 1 face-to-face meeting, nicotine replacement therapy, and phone calls. So now I'd like to share the results of the economic evaluation. Here we see the deterministic results in the short term. So when we look at the results 1 year after delivery, the intervention produces 20 more quitters amongst mothers and 4 more quitters in partners in the base case. And these numbers are 8 for mothers and 2 for partners in the cautious case. We see the QALYs gained for per mother, partner, offspring, and the whole household. And similarly, we see the cost per household here. So when we look at the incremental cost effectiveness ratios, it shows that the intervention is not cost effective, the 20,000 threshold that we use in the UK, if we are only interested in the outcomes 1 year after delivery. However, when we look at the lifetime outcomes, we see that the intervention is actually dominant over the comparator because it produces more QALYs and the cost is lower compared to the control. In the cautious case, ICER is 819 pounds, which is way below the threshold of 20,000 pounds. So it is highly cost effective in the UK. In these graphs, we see the results of the probabilistic sensitivity analysis based on 1,000 iterations. As you see, there are some level of uncertainty, but the intervention is dominant or cost effective in all of the instances compared to the comparator. So regarding the implications, the ECPH model is the first to consider the impacts of partners and the impacts on partners. It is also first to consider the severity of smoking. And the work has some significant policy implications as well. ECPH model can be used to evaluate different types of interventions and had decision makers design better smoking cessation services for pregnant women. The findings suggest that high levels of financial incentives are very likely to be cost effective for reducing smoking during pregnancy in the UK with a lifetime perspective. The study also shows the importance of taking a lifetime perspective when evaluating these interventions, because the intervention was found to be highly cost effective if we have a lifetime perspective, not cost effective if we are only interested in the short-term outcomes. Finally, there's lots of potential for future work. The first step would be piloting the hypothetical intervention after assessing its feasibility. Additionally, the ECPH model can be used to evaluate different types of interventions. This might be smoking cessation interventions for pregnant women, or for instance, some of the other interventions that are aiming to reduce secondhand smoking during or after pregnancy. Similarly, other substance use interventions can be evaluated after modifying this model. Another potential is to reparameterize the ECPH and evaluate smoking cessation interventions in other countries. I'd like to finish by saying that reducing smoking during pregnancy is a key to reducing health inequalities in society, and we can tackle smoking during pregnancy if we are willing to invest more in comprehensive cessation interventions. As this research shows, we have the tools to identify the most cost-effective ways of doing that. Thank you for listening.
Great, thank you, Tuva, and thank you for keeping to time. We'll move on to the next presentation now and take any questions at the end, but please do take note of any questions you've got. So Tom, if you could share your screens and present for us next, please.
Can everyone see the screen okay?
Yep.
Great. So today I'll be presenting the results of the economic evaluation of the IHEA trial, which aims to test a conditional cash transfer to retain women in the continuum of care during pregnancy, birth, and the postnatal period. So the objectives of this work were to estimate the cost effectiveness, and equity impact of the IHEA intervention, and the trial took place in rural Kenya in Siaya County. And with these objectives, we hope to add to the limited evidence on the cost effectiveness of cash transfers to improve maternal, newborn, and child health in Kenya and in other sub-Saharan African countries. So this was a cluster randomized controlled trial, including a total of 48 facilities. These were facilities that are known as level 2 and level 3 facilities in Kenya. So they're kind of local dispensaries or health centers that offer curative and case management services for infection and chronic illnesses. And they may cover a catchment area of 10,000 people or more. So every pregnant woman attending these participating facilities during the enrollment period for her first antenatal care visit was eligible for recruitment in the study, provided she consented to participation. And overall, our cohort was about 5,500 women who were all followed up for up to 12 months after their delivery date. And the intervention provided a transfer to all participating women for each verified visit they made to a facility for antenatal care, delivery, postnatal care, and child immunization. And all women participating in the study were given an enrollment card, which is linked to a card reader device at their health facility. And the card was intended to automatically track each visit they made by touching on the card reader, a bit like with a contactless card payment. So women in the intervention arm received a cash transfer through M-Pesa, which is a local mobile phone money transfer service in Kenya. And the transfer was 450 Kenyan shillings, which at the moment I think is about $4 or $5 US dollars. Women in the control arm were transferred a nominal gratuity of 50 Kenyan shillings of mobile phone airtime. And this was intended only to incentivize their use of their study enrollment card when attending appointments. And use of that enrollment card was intended to initiate automatic payment to both intervention and control arms. But the technology, unfortunately, did not work as intended, and there were quite persistent failures of the card readers, meaning a large number of manual payment initiations were required. And the result of this was the staff costs in Kenya were quite a lot higher than we anticipated originally. So all estimated costs reflect the actual rather than planned costs of implementation of the intervention. So they account for this high level of manual payments. And these implementation challenges will be explored in more detail in separate work resulting from the trial. So the economic analysis was from the provider perspective, and we had program costs including staff, transport, material and capital costs that were required to implement the cash transfer intervention. And these costs were sourced from the financial project accounts of each implementing institution, in particular the implementing partner in Kenya, who were the Safe Water and AIDS project based in Kisumu. Health service provider costs were also estimated to account for any increase in the number of visits to healthcare facilities as a result of the intervention. So the implementation challenges I referred to earlier also affected data collection. So it meant that a manual extraction of clinical records was required after the trial had completed, and this was used on the primary data source for visits rather than the card reader records as intended. So in short, we were able to estimate the number of additional eligible antenatal care visits amongst the entire cohort, but for postnatal care visits and immunizations, we only had data for about half the cohort. So this is a limitation of the data for other visit types and a potential source of bias. Additionally, for those other visit types, we only find evidence of an intervention effect when we remove eligibility requirements. And this means that attendance at unscheduled appointments is included. And it makes it a bit more difficult to interpret the results because although such visits probably do have health benefits, they might also reflect attendance for more minor concerns in order to receive the transfer. And all of this will be explained in more detail in the main trial paper, but for the purposes of the economic analysis, incremental cost effectiveness ratios, or ICERs, are presented for additional ANC visits, which offer the most reliable data, as well as a composite count of additional visits across all the different visit types, which is less reliable due to these data quality concerns and could represent a plausible maximum impact of the intervention. So it can be considered a form of sensitivity analysis. And further sensitivity analyses were also conducted to explore the impact of uncertainty in costs and outcomes on the cost effectiveness results. So in total, the program cost was about 800,000 international dollars, or around 300 international dollars per woman in the intervention arm. Of this total, around $230,000 consisted of direct transfers to women. And so this suggests a cost transfer ratio of around 2.4, or in other words, $2.4 was spent on administering every $1 of the cash transfer. And estimated cost to public health service providers in intervention areas was around $12,000 when only considering eligible ANC visits, or around $22,000 when using total additional visits without the eligibility criteria applied. So even if we use this kind of maximum cost of the additional burden on health systems as a result of the intervention, it still represents a really small proportion of total provider costs. So these are the main results of the cost effectiveness analysis. You can see that when using the restricted visit count, the impact of the intervention was an additional 0.3 eligible antenatal care visits per mother. And this results in an ICER of around $1,000 international dollars per additional visit. when using the expanded visit count, maximum potential impact of the intervention is around 1.3 additional visits. And so using this as our outcome measure results in significantly lower ISA of $245 per additional visit. So given the nature of these outcomes, visits and fractions of visits, we can't really make any conclusions on cost effectiveness. However, in my opinion at least, a simple comparison of the cost per additional visit with health expenditure per capita suggests that the intervention might be unlikely to be considered a good use of resources by a decision maker in Kenya, regardless of whether we use the restricted or expanded visit count. I won't go through this in detail, but we deemed a simple approach to sensitivity analysis was most appropriate for this work. And you can see that really at no point does the ISA become sufficiently low that we might be tempted to revise our conclusions. And in all cases, it remains above the annual health expenditure per capita in Kenya. So to conclude, it's unfortunately not possible to make conclusions on the cost effectiveness of the intervention. In part, this is due to the outcome being in the form of visits, and as we didn't measure morbidity, it's quite difficult to ascribe a clear clinical benefit to the intervention. And the cost estimates reflect the actual costs of delivering the intervention, but additional resources were required to manually initiate the payments given failures of the card reader technology. So card reader technology that actually works would reduce the cost substantially, and in my view would be a key requirement before any consideration of scaling up or replicating the program, especially as this could also improve the impact of the intervention. I'll stop showing now. Thank you.
Fantastic. Thank you, Tom, for keeping to time. And we have Amissa.
Oh, sorry, I was unmuted. Thank you. Can you hear me now?
Yes. Do you want to go into presentation mode? Make sure we can see your slides. We're fine. Great. Thank you.
So my name is Amissa. I'm from Tanzania. I'm working with Muhimbili University of Health and Allied Sciences, but currently I'm a PhD student in health economics at the University of Bergen, and Professor Bian and Amani are my supervisors. So today I will present some findings from the first objective of my PhD project, where we estimated the costs of implementing new recommendations from a new antenatal care model at primary health facilities in Tanzania. So a bit of the background to facilitate achievement of sustainable development targets. The World Health Organization introduced a new antenatal care model with more recommendations, some of which included calcium supplementation throughout pregnancy to reduce the risk of preeclampsia, one routine ultrasound scan to detect fetal abnormality and estimate the gestation age, to treat pregnant women with asymptomatic bacteria with antibiotics for 7 days, and then to increase the number of sulfadoxine pyrimethamine for preventing malaria. But lastly, to increase the number of contacts between a pregnant woman and a healthcare worker from four to 8. In Tanzania, we are still using the focused model. That was the previous model recommended by the World Health Organization before this one. And the focused model is grounded on 4 visits. So basically in Tanzania, antenatal care services are provided by nurses and midwives at primary healthcare facilities, which include dispensaries and health centers. So in this picture, a nurse is educating a group of pregnant women on a specific health topic. And this is normally the second activity after registration. So after this, each one of these pregnant women will receive care as needed, depending on the gestation age and the number of visits. As a country, we have achieved a lot as far as implementation of the focused model is concerned, but we still face some challenges, and one of them is inadequate resources as usual. So because the new model has not yet implemented in recommended or adapted in Tanzania, we thought it could be best to add to a body of evidence the information on how much that will cost, how much resources will be required to adopt a new antenatal care model. So we did that by first estimating the cost that was used to provide focused antenatal care at primary health facilities, and then we model additional resources that will be required to implement new recommendations from a new guideline. So we conducted a costing study from a health system perspective using a micro-costing approach at 6 primary healthcare facilities for 1 financial year. And we categorized the resources as usual, recurrent and capital cost items. But because of time, I will talk briefly about personnel, medicine, and medical supplies. So for each, we interviewed each identified healthcare personnel to self-allocate the time used to implement or to provide antenatal care services. And then we used the basic salary and allowances to value the personnel time. That was for the focused model. For the standard model, we used the baseline, that was the focus, the time that we estimated from the facility, and then we incorporated the suggestion by the World Health Organization on the amount of time that is required to implement activities at antenatal care, so that we can calculate additional time required to attend each pregnant woman 8 times during pregnancy. And for the supplies, we did documentation review to estimate actual resources that was used for the financial year. And then we used the implementation money for the new model to cost additional resources. This is the table of the results. So at a health center, the cost used to provide antenatal care services was around 40,000 USD, and that increased to almost 76,000 when we included some recommendations from a new antenatal care model. Likewise, the cost increased for dispensaries. When looking at personnel, this was the main cost contributor. More than 1/3 of the total cost was due to personnel, and the additional time to provide services 8 times for a single pregnant woman, and the cost of a sonographer. Remember, the new model recommended 1 routine ultrasound scan. So we also included the cost of a sonographer. That also contributed to the increase in the total cost for the personnel. And there was a big increase on medicine and medical supplies, because the new model recommended calcium supplementation throughout pregnancy, antibiotics for bacteriuria, more doses of OSP, and more doses of ferrous and folic. So the costs more than doubled for medicine and medical supplies. Then coming to the discussion, remember I said we used self-reporting to calculate personnel time, which we know is prone to information bias. And then we looked at the ratio between the time that was estimated to be used according to the World Health Organization guideline and the actual time. We see the potential to improve productivity, which could be translated into reduced personnel cost for the new model. But also the new model recommended 1 routine ultrasound scan, where we also included the cost of a sonographer. But unfortunately, the trial that was recommended by the World Health Organization to support that intervention found out that the ultrasound scan did not improve maternal outcomes, neither utilization of antenatal care. So there is still some question whether this will be a cost-effective intervention to implement to these developing countries. And as we saw, the cost for medicine and medical supplies increased a lot. And one of the recommendations was calcium supplementation throughout the pregnancy. But the literature, there are some literatures which shows that this is one of the least cost-effective intervention at antenatal care, based on the prevalence of, or the cases of preeclampsia. And then to conclude my presentation, introduction of a new model at primary healthcare facilities in Tanzania may double resources requirement compared to the current practice, which is the focused model. But as we know, resources availability has been one of the challenge to effective implementation of the focused model. So maybe we recommend further research from the patient perspective, because this model advise pregnant women to go to antenatal care 8 times, which adds more weight in terms of the transportation and the productivity and so on. So also we need research from the patient perspective, also the economic evaluation of some interventions which show contradicting results from other settings. Thank you.
Great, thank you, Amisa, and thank you as well for keeping to time. So thank you very much to the 3 presentations. So it's now time for the audience to have questions, comments, discussion points. I'd invite you to turn your camera and microphones on if technically able to and happy to. It'd be good to see people, but also please do use the chat function. So for those who would like to just put something in chat and I can pick those up. You can also use the raise hand function. So please do let me know if you've got any questions. I have a raised hand from Nia.
Thanks, Rachel. Thank you to all the presenters, for really clear presentations that were really interesting. My question is for Amisa. So I think your study is absolutely needed at this point because there are very few studies that actually cost up the, what it costs to deliver A and C visits. And I think that introducing 8 visits when it was hard to achieve a target of 4 visits in a lot of resource constrained areas is quite difficult. And I wondered what you might think in terms of affordability analyses. Would an 8-visit model actually be feasible for a public health system to deliver? Even leaving aside the direct costs and opportunity costs that patients might bear.
I don't know if I'll be too general, but I think it is difficult. But the problem is for most of these developing countries, for example, in Tanzania, for example, I have been hearing announcements in the radio, which are motivating men to accompany pregnant women to antenatal care for 8 visits. So I don't know if it is affordable, but I think we have, and basically most of these antenatal care interventions are vertically funded, they're donor funded. So I think that also will affect the way policymakers take up this new intervention. I don't think it is affordable, not only to the health system, but also to pregnant women who had to travel the whole day to the antenatal care. Doing that 8 times, 6 times after the 3rd trimester, it is, I don't know if it is possible, I don't know. That's my gut feeling. I don't know.
Thank you.
Yeah, thank you. That was similar to my thoughts as well. And just why I don't see any other questions at the moment. I was just going to follow on with that. So were you looking at both rural and urban locations? Because I can imagine depending on how far away you are from the antenatal care, that can make a massive difference too.
Yeah, so yes, I took that into account. So I had facilities from one of the rural setting and facilities from one of the urban setting. But then coming to the definition of rural and urban, that became difficult to present the results in terms of that. But there are, yes, some differences. If you look at the way the services are being utilized, you can see an improved utilization in the rural settings compared to in the urban setting compared to the rural settings. So yes, I had that in mind in the proposal, but then it was difficult to present results in terms of that. That's why I opted for primary, that is health center against dispensaries.
Yeah, great. So did we have other questions from the board? Yes, Deepshika.
Hello, first of all, I would like to congratulate all the presenters. You've done some wonderful work. So I have my question for Tuba. So my question is, you've presented qualities for the offspring. So what all health states did you include for the offspring? And secondly, what were the utility values that were taken? Thank you.
Yeah, thank you. Sorry, could you please repeat the first question? I couldn't catch the first one.
What all health states have you included for the offspring in your model?
Okay, thank you. So for the offspring, we had the health states as, so we separated the offspring based on the outcome of the delivery in the beginning. So if they, for instance, were born as low birth weight babies or normal birth weight babies, and depending on the results of that, and then preterm babies as well, we've included that. And depending on that, they had different probabilities of mortality and having other health conditions, like for instance, lower respiratory infections and other things. So the asthma risk was different based on the probability of low birth weight. And then when after delivery, so until they reach the age of 16, they were in the childhood model. And within that model, we had 4 different health states apart from that for the offspring. So this was for the children who weren't exposed to secondhand smoking at all. So parents might be smoking, but they may not be smoking next to the child. In this case, it won't be exposed. So we considered that as well. And then, so we had another group that were exposed to smoking by mother only. And there was another group that was exposed to secondhand smoking by partner only, mother's partner or someone else in the household. And then there was another group which was exposed to secondhand smoking by both parents. So depending on the exposure levels, the health impacts, health probabilities was different for these children. And then after the age of 16, they moved to the adulthood part of the model. In the adulthood part, so they can be never smokers, the children themselves, now they are adolescents, and they can be smokers. If they are smokers, they are grouped as light, moderate, and heavy smokers, just as well their parents. And then if they are smokers, then there are the usual effects of smoking, like COPD, lung cancer, cardiovascular heart disease, and there was one more, the stroke. I couldn't remember that one. Yeah. So these were the main things.
Thank you.
And in terms of health utilities, so we didn't assign a health utility for the unborn baby. And then after they are born, so we estimated the usual utility. So we assumed that one healthy child would have one health utility, and then if they have any conditions, they would lose some health utilities. So for instance,
so did you collect primary data for the health utilities?
No, I used the published data. And mostly from the UK. So they are not generalizable to other countries. Yeah, I mostly use data from the UK studies. Yes.
Is your study published, Yuba?
No, but it is about to. So okay, I have the manuscript submitted, so hopefully it will be.
I would be happy to have a look once it's published. Yeah, thank you. All the best with your manuscript.
Yeah, thank you. And if there is any other intervention from any country, we can easily modify the model, changing the parameters, and we can see the cost effectiveness of that intervention in another setting as well. Just to let everyone know if there is anyone interested in.
Thank you.
Great, thank you. So we've got a question in the chat from Anna Maria, which is to Amisa. Please, for the case of Tanzania, is there any evidence that the 8 visits to the health facilities significantly improve the health of the children and mothers? Having in mind all the opportunity costs, the users related to visitors, to the health facilities, which would be the optimal amount of visits. Anna Maria, I don't know if you wanted to say anything further than that, or if I should pass it over to Amissa now. Amissa, did you want to respond to that at all with the optimal number of visits?
Yeah, I will try because I have been doing this. I haven't found any literature which shows that this 8 visit will improve the health outcome of the mother or the baby. But this is the recommendation from the World Health Organization, and unfortunately, from this part of the world, most of these recommendations will be uptaken at some point. That's why we did our study, maybe to add some information. Our plan is to do a cost effectiveness analysis on one of the intervention that was recommended for the new model, but that is another objective. But as of now, I don't know if there is, because if you say the 8 visits to improve maternal or neonatal health outcomes, it has to go up to the mortality. And I don't know if we have done that, like a follow-up study to see if we recruit pregnant women for 8 months, then that will be reflected in terms of the neonatal maternal outcomes.
Yeah, it's quite interesting, isn't it? Because it's very dependent on the outcomes you get. And in some ways, unfortunately, when you're doing it in a trial or other evaluation, you're needing those negative outcomes in at least one of the groups to then look at the other aspect. So yeah, Anna Maria is just saying that she's thank you for the response, but unstable convection, not a problem. Yeah, I mean, that was one of my key thoughts with your study, Amissa. As Nia said, a really interesting, helpful study, but it is that question then, isn't it, of what's the health benefits? And for a lot of these visits, it's about identifying women who need extra care. So be it they identify preeclampsia or anything, and so they catch them to prevent the negative outcomes. But part of that is also what's available then if there is a negative outcome. So for example, if they do have preeclampsia, then what interventions can be put in place? Because if you don't have that care sorted out, then this catching them early enough almost isn't quite worth it either.
I think that was the recommendation for the focused model. So for those pregnant women who present with some complications, they don't follow the 4 visits. So they have an advanced model, which will be more than 4 visits. But for this model, it is like every pregnant woman has to go to antenatal care for 8 visits, which is a bit difficult because these women have to travel the whole day, or they have to spend at least 7-6 hours at the health facility. And then 3 or 4 times after the 3rd trimester. I don't know if that is realistic. And we have been facing a challenge to implement the 4 visits because this was adapted in 2002. Now it's 2021. It's almost 19 years, but not all pregnant women attend antenatal care for 4 visits. So jumping to 8 visits, I think it's difficult. I don't know.
Yeah, and is it spaced out evenly, or are they more pushed towards the end of the pregnancy?
No, they are pushed more towards the end of the pregnancy. So you have 1 in the 1st trimester, 2 in the 2nd trimester, and then you have 5 in the 3rd trimester.
Fair enough. So we're getting to the last 15 minutes. Does anyone have any questions for Tom at all? Because Tom, I mean, I found your study interesting in a very much I felt it was very real world. You go to implement something and it doesn't quite work. In fact, if anything, I thought that your trial was really important in that it was very pragmatic. This is almost as you could expect to see it happen in some ways. One of my thoughts were when you were talking about the missing data, you said there was potentially bias in some of the missing data. And I just wanted you to, if you could speak on that a bit more, because from what you described, it sounded like it could have just been missing at random because it was administrative. But I was wondering if you had any other clues as to why that data was missing. at all?
Yeah, sure. So I didn't do the main impacts analysis, but my understanding is that it was missing not at random. And so there were different levels of data availability in the control and intervention arms, for example. Yeah, because I think the data they used was the kind of like written clinic book that women bring to the facility. So in order to get access to that, they had to come to the facility and bring it with them. And I think less women in the control arm, if I remember rightly, did so.
Which isn't surprising, seeing as the point of the intervention was to improve their engagement. So in some ways,
exactly.
it makes sense you had more data in the intervention arm because they were meant to be attending more and actually being more engaged. Yeah. And I just think it really highlights the challenges in this kind of research as well, which I thought quite interestingly overlapped a bit with AMISA as well, and that these are quite challenging places to do this kind of research in. And I don't know, in particular, Tom, did you have any thoughts in how you overcame some of those challenges, or your thoughts on the challenges at all?
Yeah, it might be worth just commenting on some of the links with AMISA's work, because I think in our control arm, there were on average 2 antenatal care visits per woman. So reaching 8, I think, would be extremely challenging, especially as the gestational age at first interaction with the facility is generally quite high in our context. So I think that is really difficult.
Thank you. Deepshika, did you still have a question, or have we got a legacy hand there? I'm not hearing anything, so I'm assuming it's a leftover hand. I thought I'd bring it back to Tuba, your presentation. You made an excellent point about reducing inequalities at the end there, and with the smoking cessation ones. And in particular, I really liked the idea of the intervention, that it was very much about engagement with the woman. So some of these interventions can end up being a case of blaming in some way, and this person does this negative behavior, but the way that you framed it was very nice in terms of bringing the woman along on the journey and improving the health. But you mentioned inequalities, but there wasn't a lot presented there on inequalities. As part of your trial, are you wanting to then address some of that equity inequalities aspect more specifically?
Thank you very much for highlighting that. Yeah, I think it's a really important issue. So also I want to highlight one more point. So in high income countries, we know that smoking during pregnancy is really common in disadvantaged populations, or let's say women, for instance, work in manual labor, or women with less education are more likely to smoke during pregnancy. And then even if they reach out to the NHS to get the smoking cessation services, their quit rates are much lower compared to those at the higher end of the health gradient. So, but it may not be the case in some low and middle income countries. From low and middle income countries, we have limited data on health inequalities aspects. So what I'm going to say now about health inequalities mostly is related to high income countries, and specifically the UK. So what we considered is that designing an intervention that includes financial incentives and a household approach actually targets those women from the disadvantaged backgrounds, because this would attract more attendance. So at the moment, the attendance rate is around 25%. Only 25% of women who smoke during pregnancy engage with the NHS. And then amongst those, only around 27% quit at 4 weeks after being engaged with the NHS. So if we can get more women to be involved with the service by involving a more comprehensive intervention, we would be able to reach out these more disadvantaged populations as well. Another consideration was that with this intervention, the idea was that to integrate this into antenatal care. It is already a part of a plan. So there's something called the continuity of care. And then it is considered that the midwives would go and visit these women throughout their pregnancy at several occasions. So ideally, it would be really great to integrate this smoking cessation advice and intervention into that, and then use the trust between midwife and women as an opportunity to reach out to the women and their household with this intervention. So this is a way of increasing attendance as well, because we are going to them rather than them going to us. So this may not be feasible in some low and middle income countries because of limited resources, but it is potentially possible in the UK or similar other countries. And in addition to that, so this is a short part of a bigger study. We also designed another intervention for considering reducing smoking during pregnancy. So currently, most of the interventions actually are focusing on helping women to completely stop smoking. But with this model, we can also see the impacts of helping them reduce smoking as well. So if they are heavy smokers, we design an intervention to help make them, let's say, light smokers during pregnancy. Is there any impact on health outcomes? And I've done another study, another evaluation to see the impact of reduction in smoking during pregnancy interventions. And this shows that actually it is cost effective in the UK as well. So this is another way of addressing health inequalities, because if they are not ready to quit smoking because of their circumstances, or if they just don't want to quit smoking, then we can offer help with at least reducing smoking for the sake of baby and for the sake of themselves, of course. So I think this is a good way of giving them another option without patronizing, without considering their conditions and situations. Yeah. Thank you.
Yeah, no, it's an interesting point, isn't it? Because the smoking cessation services, I mean, they're shown they're so cost effective to stop people from smoking because of the massive cost associated with it. But it's just then how much can you invest up front to then bring those smoking numbers down, and to what extent you bring the smoking numbers down. Yeah, no, it's great. And also the involvement of the partners as well. I've been looking at a bit of research recently of the more partners are involved, the then healthy influence on the mother's behaviors as well, which is interesting.
Yeah, definitely. It increases the quit rates and it reduces the relapses after, let's say, 1 year as well. Because most women, even if they quit, so based on trial data, we know that even if they quit, 80% of them go back to smoking within a year. So we want to reduce, or at least, I don't know, reduce that number, even if we can't prevent it.
Yeah. So we've got 5 minutes left. So I want to double check if there's any other questions that people have at all.
May I have a question or a comment?
Please do.
So I found, I would like to thank Tom and Emisa for their presentations. And I was wondering their views on integrating such an two-mom intervention in the settings that they worked based on their studies. So you both considered a new study that is related to continuation of antenatal care. How possible would it be to integrate smoking cessation advice to those services? And do you think, for instance, the impact of your work could be maybe measured with the effect of reduction in smoking as well in those settings? I don't know, just as a thought, I'm really curious about this.
I mean, it's an interesting idea. To be honest, I don't really know much about prevalence of smoking amongst women in our study, and I don't think that's something we measured.
Yeah, okay, thank you. It might be low, yeah. In some low and middle income countries, cigarette smoking is low, but tobacco smoking is common, and we can use the same methods to help them with reduce or quit tobacco use as well, hopefully. I would appreciate any comments or feedback on this one. Just, see how applicable these findings to low and middle income countries now or later. Thank you very much.
Yeah, no, I definitely agree with the tobacco use one. We've got an intervention in India looking at reductions in tobacco chewing use. So yeah, that's definitely an interesting crossover. And it is interesting as well, the crossover between all of them in terms of engagement with services, be it in lower middle income countries or in the higher income countries like the UK, where even you get groups where they need engagement with services to then improve health and again, pick up on these problems earlier on. So I don't think I'm seeing any other chat or any other comments at all. So obviously you're invited to more hopefully contact any of the speakers if you've got any questions. There is within the IHEA forums, as you may have seen and been told through other sessions, there's an ability to chat through there. So there's plenty of networking opportunities if you have any questions after this session at all to then meet up with the authors on. So I'd like to thank the three authors again for three very excellent presentations. It's been an enjoyable session and I've been very pleased to be the moderator for this, and thank you very much as well for the audience participation. So yeah, and I can see Tuba's just given her email there for if anyone's got any questions. So thank you everyone, and yeah.
Thank you.